Thank you for joining us for the 47th annual AAKP National Patient Meeting. My name is Terry Litchfield, and I'm an AAKP Ambassador from the state of Wisconsin. I'm a former caregiver and a dedicated patient advocate. My husband Bill was an early pioneer in dialysis, starting in 1968, and was on home hemo for 21 years. We were married over 30 years, and I know firsthand what the role a family plays in the success on dialysis and with kidney failure. I continue the efforts he started more than 50 years ago. AAKP is the kidney patient organization, and I am honored to continue to be a part of AAKP. As a kidney patient advocate, I've had the opportunity to visit with congressional leaders to change laws to help patients. I've worked with other patients and care providers to give voice to our concerns and our requests. It has been exciting to see kidney disease become something that's talked about, the golden child in Washington, D.C. of this decade. And I'm very excited about the new things coming our way, making lives easier for patients with kidney disease. Being part of AAKP has allowed me to give voice to kidney patients and give back to an incredible patient that allowed my husband to thrive on dialysis for more than 40 years. With over 30 years professionally in the healthcare field, and an emphasis on dialysis care, I know very well the clinical and personal impact of dialysis and kidney diseases. As a co-founder of Lifeline Vascular Access, which provided me with a unique insight into current healthcare environment, and particularly those involving kidney patients, because you need an access to be able to connect to the kidney machine. It's been encouraging to see the progress that's been made, which is long overdue. I am so happy to moderate today's session's New Technology for Dialysis Access Creation and Maintenance. We are so honored to have with us a good friend of mine and AAKP's, Dr. Ari Kramer. Dr. Kramer is an assistant professor of surgery at Spartanburg Medical Center, where he has served as the principal vascular access program director and surgeon since 2005. He not only places accesses, he repairs them, and he gives great pride in knowing his patients personally. He has fostered the advocacy development of more than one patient, and he has really provided patients in upstate South Carolina with splendid vascular access care. His professional accomplishments include teaching awards, presentations, peer review articles, educational sessions, quality improvement projects, and emerging technology trials for improving cares with renal impairment. We are thrilled to have Dr. Kramer with us today to provide updates on technologies and innovations in vascular access. Dr. Kramer, I turn it over to you.
Hi, many thanks to Terry Litchfield and the AAKP for having me to discuss with you our new opportunities in AV access. My name is Dr. Ari Kramer, and what I am going to do is be discussing with you new technologies for dialysis access, creation, and maintenance, letting you know that the future is now. These are my relevant disclosures. I'd like to start out by referencing the problem because I think that every problem, in fact, does have a solution, and it just may sometimes need another perspective. Nothing could be more clear than that being the message within the AV access space, and specifically within chronic kidney disease in general. And today I'd like to take the opportunity to discuss with you the reasons for why that is. In the United States, there are some 37 million adults who are estimated to have kidney disease, also known as chronic kidney disease, and approximately 90% don't know that they have it. That means that up to 1 in 3 adults in the United States are at risk for kidney disease. Risk factors for kidney disease include diabetes, hypertension, obesity, family history, and blood pressure issues in general. So Black people, African American people are more than 3 times as likely as white people to have kidney failure. Hispanics and Latinos up to 1.5 times more likely than non-Hispanics to have kidney failure. Approximately 785,000 Americans have irreversible kidney failure and need dialysis or a kidney transplant to survive. 555,000 of these patients receive dialysis to replace their kidney function, which is delivered in a dialysis center 3 times a week, 4 hours at a time. 230,000 are fortunate enough to receive a transplant. There are approximately 100,000 people on the wait list for a kidney transplant right now, with an average wait time for a kidney to be upwards of 3 to 7 years, depending on your locale. And what this brings us to is the fact that innovation in AV access is necessary and it needs to occur today. The very first thing I think we should understand is that hemodialysis is the dominant therapy that occurs in dialysis for patients currently. There are 2 modalities which provide this. Both of these access types are covered by your skin. Those are arteriovenous fistula, and the second are arteriovenous grafts. A third type, which is the least recommended and the least safe option, is a tunneled central venous catheter. Today, I'd like to talk to you about percutaneous fistula. This access is generally considered to be the first choice of access that is beneficial for patients to give us the healthiest means to receive dialysis. Unfortunately, up until present times, a surgeon was required to achieve this access type for patients, and there were often delays as surgeons are quite short in their supply. Thusly, having opportunities to provide access with new modes of technology have been up and coming and are now available in many centers across the United States. As we look at this opportunity, we can see there are 2 options. The Ellipsis vascular access system, which Medtronic has provided, which offers a single point of venous access that makes the AV access available to the patient immediately in an inpatient or outpatient setting, eliminating the necessity for being at a hospital center. Also in this space is the Wavelink. The Wavelink was an initial device that was founded by BD. And this device is also an outstanding opportunity to create an AV access in the outpatient center. Collectively, these devices solve a very important problem. Number one, because there is a shortage of dedicated access surgeons, AV access has been challenging, and it has been very difficult to get patients into systems to develop their AV access in a meaningful way. Next, this expands the pool of opportunity by allowing other healthcare providers to create this access without necessary surgeon to be involved or to have a specific role in the care of maturing those AV access, which speeds the rate of AV fistula creation and subsequently reduces the risk of patients requiring hemodialysis with central catheters, which are highly risky for patients because of problems and complications such as central venous stenosis or narrowing, which can eliminate future options in the AV access space. Also creating high risk for infection and other very aggressive complications that can require hospitalization and can even lead to death. The very important consideration is the timeliness in which these accesses can be created, which is at the same day often as the patient is evaluated. Also, noting that the access can be created in a very consistent manner and is highly effective and reproducible, and again leads to a permanent hemodialysis access that is exactly the same or superior to a surgical AV access creation. But unfortunately, we also know that some patients don't have adequate veins. Their venous system has been used by other failed AV fistulas and interventions, or perhaps patients have had hospitalization and multiple lab draws where the veins are just not enough quality, or skin problems may lead to issues that the vein is just not felt to be adequate to support needle cannulation. And this leaves us with the necessity for AV grafts. AV grafts are prosthetic materials. These are materials that are not your vein, however, bridge the difference between the artery and the distal vein and allow a cannulation expert to use the access to still achieve hemodialysis. In this space, Innovasc is designed to reduce the risk of complications and bleeding from AV access grafts. As we know, when we experience dialysis in a center, missed cannulation or infiltration of an AV access can occur, and this can become quite challenging for patients to deal with, as well as lead to fear of cannulation. So what does the Innovasc technology supply us? It supplies us a novel technology that allows reproducible cannulation in a very systematic way that a patient and clinic staff member can either cannulate that access in a standard rope ladder or continuing to move the needle in the cannulation zone routinely. It resolves the issue of excessive bleeding after the needles are removed from the AV access due to its unique properties of the construction of the AV access. This, in combination, improves cannulation confidence and security and has expanded the opportunity for patients to receive successful dialysis in outpatient clinics, as well as the consideration of returning to a home setting with confidence that they too will be able to achieve dialysis in a very well and healthful manner. Drug-coated balloons. This is an expanding and necessary therapy because we also know that AV access will fail. Unfortunately, much like a car, dialysis access requires maintenance. It requires continued surveillance to make sure that adequate blood flow can be achieved such that the metabolic wastes from dialysis or a failed kidney can be met by dialysis. When blood flow slows down, the ability to clear those toxins is dramatically reduced. Unfortunately, heretofore, what we had were only plain balloon angioplasties available to us, where a doctor or an interventionalist, a surgeon, etc., would provide a single puncture to the AV access, negotiate a wire across the area of concern, image that area, and then stretch the area with a balloon. This process is known as plain balloon angioplasty. Recently, very detailed studies have been done to examine how this therapy works best. And what has been determined is that drug-coated balloons with a special molecule called paclitaxel help to advance the outcomes in the durability and maintenance of AV access circuits. Specifically, Medtronic had a very large series of patients that was able to achieve 80% of primary patency through 6 months. This was the largest pivotal trial to show clinical significance and an advance for patients. In plain English, what does this mean? This solves recurring intervention to maintain AV access patency, where standard balloons can achieve 50 to 60% access patency, where blood runs efficiently and smoothly. This can be extended out all the way to 80%, reducing the number of times you have to see your doctor for therapy to save the access and maintain the access. There's subsequently less reliance on artificial implants to maintain the AV access function, reducing stent usage, etc., and saving those for more emergent complications or necessary secondary procedures as your clinician may see fit. There are less likelihood now of seeing access clotting and loss of access, which can return a patient back to tunneled central venous catheters, which is again the least healthy methodology to receive dialysis. All in all, what do drug-coated balloons and specifically the Impact AV DCB mean for patients? They mean improved patient freedom. freedom to continue your life independently without trips to your interventionalist. But what about other fistula products, such as VasQ? Arteriovenous fistulas, or veins connected to arteries, have a natural failure rate where the vein attached to the artery creates turbulent flow. The body was not designed to create an AV access circuit, and consequently, it responds in such a way that requires intervention. When a surgical fistula is provided for a patient, the same mechanism of failure occurs as in any other access. And in this case, stenosis or narrowing occurs within the AV access circuit. And we can see that on the right side of the viewer screen where narrowing has occurred. Because of the VasQ having a skeleton that is placed around the access, it causes an outward remodeling. This helps to improve fistula maturation. It reduces the stenosis, where the area of the artery and the vein join, and improves fistula usability, reducing the total contact time with a central venous catheter, or sometimes obviating the need for a catheter at all. Well, how about home kidney replacement therapy? For years, patients have been encouraged to receive hemodialysis access, but many patients have a strong desire to return to the home center. They have a strong desire to control their own care. However, previously, large, bulky dialysis machines and products have caused quite a bit of difficulty for patients who have the disadvantage of space or an inadequate supply of water and waste place to use a dialysis machine in their home. However, now, thanks to this Quanta, which is an award-winning design, patients can now use this revolutionary dialysis machine, which weighs just 90 pounds and occupies a very small footprint, hook up to their standard water supply, and use cartridges to exchange the dialysis machines and keep them clean, reducing the risk of infection. So what does it solve? Well, it saves time. It reduces risk by, again, using disposable cartridges that generate diacylate, which is the fluid that's necessary to create the exchange for appropriate dialysis. It eliminates the need for disinfection and, again, reduces the ever-present risk of infection. This easily, again, integrates into your existing water structure. And it is compact and lightweight, allowing greater flexibility for home use and remote monitoring. Speaking of remote monitoring, we know that accesses are always running. However, we only have been typically able to evaluate their function intermittently while the patient was in the dialysis center. However, secondary to wearable technologies, devices such as Aleo have allowed patients to live with peace of mind, knowing that their access is under continuous monitoring. While patients are mandated to be monitored, it has typically been very challenging. But with this wearable device, patients now have a non-invasive way to continually assess their access, to check for elevated potassium levels, to check their hemoglobin and hematocrit, to know their blood pressure, to evaluate for fluid overload, and exactly know how well or efficient their access is running to help assist their care team to provide meaningful therapies such as the ones that we've described earlier. Thank you for your attention. I hope that you found this talk useful and can use the opportunity to discuss some of these beneficial technologies with your care provider to improve your life and achieve safe and healthy outcomes.
Thank you, Dr. Kramer, for such an incredible presentation. And I know I'm speaking on behalf of all the patients listening. We can't wait to see some of these innovations come to us. We thank you for sharing your time and your expertise.